All right, thank you. So I greatly appreciate the chance to talk about two of my most favorite topics. Part of the reason I like giving this talk is because these are extremely common problems. So unlike some of the things we see in orthopedics that is relevant pretty much only when patients see us, knee arthritis and meniscus tears are the most common things that everybody sees, whether it's family members, friends, patients, loved ones. It's extremely common. And the other reason I love giving this talk is because there actually is some evidence for a variety of the things that we're going to talk about. Most of the time when we talk about orthopedics, there's some limited evidence. It's usually level 4, level 5 evidence. For meniscus tears and arthritis, we actually have a lot of good evidence for many of the different treatment options that we have. Unfortunately, a lot of the treatment options that we have support not sending your patient necessarily to orthopedic surgery, especially if it's been in the New England Journal. So what I'd like to cover is two topics that are very related: degenerative meniscus tears and knee arthritis. This is different than the meniscus tears that Dr. Allen talked about. This is different than your high school or college athlete or your 30-year-old with a meniscus tear from an acute injury. We're going to focus more on the degenerative meniscus tears, and we'll talk a little bit about why those are different. And then we're going to spend most of the time on knee arthritis and what the different treatment options for those are. For the most part, I'm going to try to focus on studies that are good from the last 5 years, give or take. Unfortunately, these studies aren't always perfect, so sometimes we have to pull from older studies, especially if they're really relevant. So when I was making this talk, I was trying to think about, well, how does evidence-based medicine really fall into what patients want? First of all, evidence-based medicine suggests that the better the quality of the evidence is, the more likely we should support that as a treatment decision. For better or for worse, patients also want personalized medicine. I often have patients say, well, I know my body, so therefore I know what's best for me. And the reality is they very well might know their body, but the way I like to think about it is that we can use evidence-based medicine to help guide them with the different treatment options and have them develop a shared decision-making mindset where we can help them come to the best decision that both of us are happy with. So I'm going to start with evidence-based treatment for degenerative meniscus tears. These are typically meniscus tears, like we talked about, that have minimal or no trauma. Oftentimes, these are older patients. I say older now means over 43, but really 50 to 75 years of age. They're often not acutely swollen. They may not have a great mechanism of injury. So whereas a meniscus tear like Dr. Allen was talking about would say something along the lines of, oh, when I was playing basketball, I felt something, I knew it was bad. These patients will say something like, well, when I sit in the car, I notice my knee hurts a little bit. And you think, how many times of the many times you get in and out of the car did you actually hurt your meniscus? Well, it's pretty rare. So the mechanism doesn't always make sense. And these can actually be incidental findings. Well, how is this an incidental finding? Well, you figure that somebody comes in with a medial-sided meniscus or medial-sided pain, you get an MRI, and it actually shows a medial meniscus tear and a lateral meniscus tear. So oftentimes the patient didn't even know they had a lateral meniscus tear until you get advanced imaging. So I think this was a really good study that came out of the Washington University orthopedic group, and they highlighted the difference between traumatic and degenerative tears. And what they did was they took samples from meniscus from degenerative tears and samples of meniscus from traumatic tears and ran high throughput PCR to look at gene expression. And what they found through a very complicated array of gene analysis is that the tears were fundamentally different in about 60% of gene expression patterns. They found that traumatic tears had many more inflammatory markers. The knee was much more inflamed, it was more swollen, and there was less collagen and more collagen breakdown products in the degenerative tears. So this study, they concluded that highlights the difference between a degenerative tear, something that may be more related with arthritis and wear and tear of the knee, compared to an acute traumatic tear, and this suggests we may need to treat these somewhat differently. For better or for worse, we have really good evidence that in the setting of arthritis, meniscus tears probably don't need to be operated on. So the first study was done all the way back in 2002 in a cohort of VA patients in orthopedic surgery. We call this the Mosley study. What Mosley did is he took a cohort of VA patients with a variety of levels of arthritis, but usually more advanced arthritis, took them to the OR and did either a debridement or a sham surgery. So the sham surgery was they played music, splashed water on the floor, made little portals, walked around, talked, patient was asleep for it, and then woke them up. What they found was that there was absolutely no difference at any time point in any of the primary or secondary measures. So subsequent to that study, most orthopedic surgeons said, well, Dr. Mosley, it's not a great study. It's VA population. My patients are different. So Sandy Kirkley repeated the study in Canada and said, well, we're going to do the exact same study, but in a wider population. We're going to include women or more women than the Mosley study did. And for better or for worse, they found the exact same thing. There was no difference between sham surgery and real surgery for people with arthritis and a meniscus tear. So people in Finland said, well, that's the Western Hemisphere. We don't believe that. We're definitely different. We're Finnish. We have a cool flag. We're really north. We have narwhals up north, some polar bears. So we're going to be different. So they did the exact same study. They published this in 2013. And unfortunately, for orthopedic surgeons, they found the exact same thing. They found that there was no difference in people with some arthritis, but these patients had less arthritis. These were patients who had minimal to no joint space narrowing. They found that there was no difference for degenerative tear debridement versus sham surgery. And this year they followed up their study looking after 2 years if there was any difference, and importantly, were there some patients that you could tease out a difference? I think of what a lot of patients really want to know is there something subtly different about their meniscus tear that makes them different? For better or for worse, that they found that even mechanical symptoms or type of tear didn't make a difference in whether or not the sham surgery or real surgery improved their outcomes. So the conclusion from these studies suggests that in the setting of mild arthritis with a degenerative tear, we do not need to jump to surgery. And we'll get into how you discuss that with patients. So what do you do for your patients with meniscus tears in the setting of arthritis? So this was a really nice study finally done in the US in a normal population. This was done by a variety of groups, but it was centered both in Boston and at Washington University. And I know the print is really easy to read, but basically what they did was they took a large cohort of patients, divided them into two groups. One got physical therapy, which was standardized twice a week for about 12 weeks, and the other group got randomized to surgery. What was interesting about this group was they were allowed early crossover. So that's in general when you do a randomized control trial, you don't want to allow early crossover because you want the patients to kind of complete their treatment arm. But they said whenever you're not happy, you can decide to go to the other group. And so if I'm designing a study, it's not ideal, but it's more realistic for the patients, especially if you're randomized to the group that you were hoping not to get. So what they did then was they looked at these patients for 1 and 2 years, and their results are really interesting. At 12 months, they found that both groups, whether they had the partial meniscectomy or physical therapy, were doing exactly the same. The arthroscopic partial meniscectomy group got better faster, both for a physical function and overall pain score, but at a year they were about the same. So this is really, really nice data you can bring back to patients. No matter what you do, a year from now, you are going to be doing better. Whether you want surgery or physical therapy, you are going to be doing better with your degenerative meniscus tear. But what was most interesting about this study was the crossover groups. And what they found is in the crossover groups, so these groups mainly started physical therapy early, so this is this bar here, this bar, and this bar. This group crossed over early. They started physical therapy, said, it's not for me. I want surgery. So they were switched to the other group. This group that did physical therapy first and crossed over actually did slightly better than every other group. So this is my way of convincing patients to do physical therapy first. They might not need it, they might not get better, but if you get better and you don't need surgery, that's a win. If you get better but not better enough and you have surgery, you're going to do even better. Great. Even the patients that crossed over late still were on a trend at 12 months to getting better. So no matter what you do for these patients, whether it's physical therapy or surgery, they're going to get better. So the way I discuss this with patients is we can do a variety of different things. Meniscus surgery in this setting is a 15 to 20 minute procedure. Its risk is less than 1 in 1,000 of having a real complication, including bleeding or infection. A medical complication from these are really, really low. But the reality is this surgery is probably not necessary, and it's totally totally elective. So there's no reason to have surgery for this. Conversely, if you want to avoid surgery, avoid being on crutches, avoid incisions and scars in a place you have to put a tattoo over to get so people can't see your scars, then try physical therapy first. The worst that happens is you get better a little bit slower, and that's the worst that happens. So in summary from these studies, I think what we can say for sure is that surgery for arthritis and meniscus tears is really not beneficial. We know from a variety of studies, 3 well-done studies, that we do not need to operate on these patients for their meniscus tear. Physical therapy for degenerative meniscus tears is beneficial, and that's been shown in this study as well as others. Surgery for degenerative tears might make patients get better a little bit faster. So you're really anxious patients, they want to get better now. Surgery is not the worst option for them. And surgery for meniscus tears is absolutely not necessary. Having a meniscus tear is kind of like a fact of life. As you get older, it's extremely common. It's important to tell your patients that they may not need surgery even though it says there's a tear. And I'm sure when you hear about shoulder later in this course, you hear that over and over. Having something on your MRI report that says degenerative or torn is normal. So I wanted to switch gears a little bit now and try to answer some of the questions that we get most commonly, and I'm sure you guys get commonly as well. And one of the most common questions we get is, does having a meniscus tear mean either I'm getting arthritis, or if I don't have this surgery, or if I don't have this treated, am I more likely to get arthritis? So there's a large cohort of patients that are enrolled in a study called the Osteoarthritis Initiative. It's similar to the orthopedic version of a Framingham study. Everybody who had a little bit of arthritis and normal controls were enrolled, and they were followed both with x-rays, MRI, and a series of demographic criteria were entered, and then these patients were followed up over a period of time. So it's been a tremendously useful way to get a lot of data on patients and get a sense of what the progression of arthritis is in a cohort of patients. What they found for this question is whether or not a meniscus injury influences arthritis. They focused on the medial meniscus, and they found that it was not significantly higher overall. So just having a meniscus tear itself does not seem to indicate you are going to get arthritis in this cohort. However, if you look at their p-value, well, it's 0.07, which technically doesn't reach statistical significance, but they may not be well powered enough to get to that data. So it may be that if they had more patients, they would find that meniscus tears are a predisposing factor to arthritis in this cohort. So what they did to combat that is they said, well, are there certain factors that may make it more likely that you develop arthritis? And they found that there are some factors. So bigger meniscus tears, so a complex tear that extended all the way to the periphery. Similarly, a tear with a large radial involvement, a tear that essentially goes all the way through the meniscus, you are more likely to develop arthritis. And if the whole meniscus is extruded, basically every time you walk, the meniscus is pushed outside the joint line, it makes sense. Those patients are going to be more likely to develop arthritis. So what I conclude from this study is that there are certain tears that we may want to tell the patients, these are more likely that you're going to develop arthritis, but overall you may not be any more likely than the normal population once you have a meniscus tear. The other question that we get, which is kind of hard to answer, is, well, I have a meniscus tear and now you're talking about taking part of my meniscus out. I have lost no parts of my body yet. My appendix is there, gallbladder is there, 90% of my hair is still there, I'm still 6'1", so I don't want any part of my, I'm actually 6'3", so it's okay. I don't want any part of my meniscus removed. So we did a study a few years ago where we looked at a couple different things. And what we're able to do is we're able to get a high-resolution picture of the meniscus, and we tried to correlate how much we took out at the time of surgery and whether or not that influenced the amount of degeneration 6 months or a year afterwards. And what we found overall is that we did see some cartilage changes right around where we did the meniscus resection. So we found that if we took out about 20 to 30% of the meniscus, so this meniscus is missing about 20% in the posterior horn, we found that the cartilage changed in the superficial layer. So having both the injury itself as well as the meniscus surgery probably influences that local mechanical environment, but it wasn't enough to say for sure that the meniscus surgery is going to change the outcomes. So the way I really think about this is once you have a tear of a biomechanically important structure, once that biomechanical part is gone, us removing the part that's not doing anything is probably not changing the natural history of the knee, but it may make you symptomatically better. In a perfect world, we would be able to repair all meniscus tears, but it's not feasible due to the fact that most meniscus tears are pretty beat up and degenerative. They aren't able to hold sutures, and there's a very little blood supply within the meniscus. So even if we were to put many, many sutures in the meniscus, it might not actually help healing. So my treatment algorithm when I see patients with degenerative meniscus tears, which is about the third most common thing I see in clinic, if you focus on the bottom half of this, when I see somebody with what I think is a chronic or degenerative meniscus tear, and their x-rays show no arthritis and they have an MRI that has a tear, tell them, hey, look, there's really good level 1 evidence that physical therapy will work for you. So let's try physical therapy. If you're swollen, if pain's really bothering you, we can try an injection. And only if surgery is only an option for you if you fail non-operative management, because we know there's a good chance you'll get better without surgery. And if you don't get better without surgery, if we do surgery at a later date, you will still get the same benefits. If patients have mild to moderate arthritis on x-ray and an MRI tear, I really, really try to encourage them. There's good evidence that it is as good for me to fake the surgery than to do a real surgery. And if the patient still wants surgery at that point, I'm going to say, why not? Honestly, I'm a surgeon. I like to do surgery. If I tell a patient it's better for me to fake the surgery than do real surgery and you still want surgery, you are a great candidate. I'm going to do surgery. All right. So let's switch gears again and talk about knee arthritis. Knee arthritis is extraordinarily common, like Dr. Allen told you. I want to back up just a second and talk about what arthritis is, because I think it's one of the things that I think we forget sometimes. Words that are really basic to us are hard for patients to understand because they're common. Patients hear the word arthritis, they have no idea what that actually means. So if we look at cartilage, which is the smooth cap on the end of all bones, so this is your medial femoral condyle, this is your tibial plateau, that's your medial meniscus. Cartilage is ridiculously smooth. My kids ask me, how smooth is smooth? I say it's like Justin Bieber smooth. It's smoother than taking a piece of ice and sliding it across another piece of ice. The coefficient of friction is so good, it's the lowest thing that we have known to man or anybody else. When you have normal cartilage, it has a lot of really good things. It's super smooth, like we talked about. It has no nerve endings, which is fantastic. You can't feel your joints move on a daily basis, which is wonderful. You can imagine how distracted you would be if you could feel all your joints move all the time. The problem with this, though, is you don't have a lot of cells. That's why it helps. That's part of the reason it can be so smooth. You can't make more cartilage. Dr. Ma talks about cartilage as an inherently lazy organ. Once you have cartilage damage, without the cells there, you can't regenerate cartilage very well. So we don't have the ability to stimulate our own cartilage to generate more cartilage. It also, because it has no nerve endings, there's no early warning system in your cartilage. You think about if you get close to a fire and you put your hand really close, it says, ow, it's hot. Your body has no idea it has arthritis until you've lost a fair amount of cartilage. So it's good. Cartilage is really, really, really good until it's bad, and then you're kind of hosed. Good for surgeons, bad for patients. History of arthritis, you already know this. Symptoms of arthritis: pain, swelling, loss of range of motion, deformity, inability to do the things patients want to do. Physical exam findings can be pretty nonspecific. Sometimes they have a deformity. Sometimes they'll describe crepitus, but every time if you ask a patient, does your knee click? Yes, it does. It just does. They can lose range of motion with advanced arthritis, and they have tenderness along the joint line, but often not along the joint line like along the meniscus. It's often a centimeter or two above or below. When you get imaging for arthritis, like Dr. Allen mentioned, obtain weight-bearing x-rays. And remember that the severity that the radiologist tells you, they'll call this mild arthritis, moderate, and severe arthritis. That does not correlate with symptoms. You can tell somebody you have severe arthritis, and they'll say, I don't actually have that much pain. You say, that's great, you're really tough. But how bad the x-ray looks does not correlate with pain. So what are the treatment options for arthritis? So thankfully I have 5 fingers, and there's really 5 good treatment options for arthritis. There's also, this also helps me remember how many Law and Order different episodes there are. So activity and lifestyle changes are I tried to make a joke. Oh, well. Activity and lifestyle changes are most important. That's why it's on the thumb. We'll talk about the evidence for physical therapy. We're not going to talk much about bracing and unloading. We'll talk about injections both now and later today. And we'll touch on surgery, which essentially is a knee replacement. So in addition to the different treatment options, I really try to break this down for patients in modifiable risk factors, non-modifiable risk factors, and things that are possibly modifiable risk factors. So in modifiable risk factors, your activity and activity levels, your weight, if it's within a reasonable BMI, meaning your BMI is 30 to 35, you know you need to lose weight, we can work with you on that. And engagement in your healthcare. I think arthritis is one of those things that if you take charge of your own healthcare and you make patients kind of get a good sense of that they can take care of themselves, they will help themselves get better more than you can. Possibly modifiable, really obese patients, which we don't see a ton of in California, but this is something that we can help them with, and there's good evidence to show that bariatric surgery will help patients. Alignment, if they're very varus or valgus, their knees are knock-kneed or bow-legged, you're mechanically overloading that joint, we can help that with osteotomies or cutting the bone to realign you. And your biologic environment, and we'll talk a little bit about this, but this is probably something that we'll be better at in the next 5 to 10 years. And then unfortunately, there's non-modifiable factors. There is a genetic predisposition for arthritis, and some patients get injured. If you've had 3 ACL tears in your past or 2 ACL tears, a meniscus surgery, and a cartilage surgery, we may not be able to go back in time and fix that, but we can work with you to try to get you better during that time. So the first thing I tell patients in terms of lifestyle changes, and I have 2 caveats. One, most of this data is from the guidelines from our Academy of Orthopedic Surgeons. And the second is if I made any changes to the slides, I apologize. I get excited the 48 hours before a talk, and sometimes I add things in. Please don't write, the syllabus was wrong by a slide. It's just because I got excited and added a slide. Joint juicing, glucosamine, and chondroitin. How many of you have had a patient ask whether or not they should take this? Okay, pretty much everybody. How many of you take this? Okay. How many of you like going to Hawaii? Oh, come on, really? Everybody likes going to Hawaii. All right, so the cost of 1 year of glucosamine and chondroitin is a round-trip ticket first class on Hawaiian to Kauai. You don't have to stop, you land, you get off, you're happy. There are multiple studies that show that these are no more effective than placebo. So our recommendation to patients is go to Hawaii. But really it's send us to Hawaii and do not spend your money on this. Spend this on a gym membership, something that makes you happy, a bike, something that gets you outside because it's more likely to be effective. What about anti-inflammatories? Well, especially in San Francisco, I have many, many patients that say, well, I don't like taking pills. Like, you smell like something that's very herbal, but you don't like taking pills. That's okay. But the evidence is that ibuprofen or other anti-inflammatories decrease inflammation. That's not the same as blocking pain. That's the other thing I hear a lot from patients is, well, I don't want to mask the pain. Well, why not? I mean, of course you want to mask the pain, but if you mask the pain with something that actually decreases the pathology that's happening, that's a wonderful thing. And the fact that that at Costco is much cheaper than the glucosamine is a wonderful, wonderful thing. So there's very good evidence that low to medium doses of anti-inflammatories, especially when your symptoms are flaring up more, is very reasonable. So our recommendation is it's pretty strong evidence that this will make you feel better. But the most important thing we can tell people is that if you're overweight, losing weight is very important. And it's hard to tell patients that because, first of all, patients know they're overweight when they're overweight. It's not like you tell them and they go, oh my God, I can't believe you told me that. They know that. They just don't want to hear that, right? What we do know is that surgery, especially joint replacement, does not lead to weight loss. And that's very important to tell patients. The snarky way to say that is that if I give somebody a knee replacement, that just means they're going to go back to doing the things that they want to do, like eating and not exercising a little bit easier. But the reality is over the course of years and years and years, your habits are ingrained into you. And if you get a knee replacement and you haven't been healthy beforehand, you're not all of a sudden going to be healthy. But what we do know is that weight loss leads to markedly less knee pain, and it isn't a lot of weight loss. 10 pounds of weight loss leads to 40 pounds of force off your knee with each step, which over the course of a day, a week, a month is a tremendous amount of weight loss. Sorry, same amount of weight loss. a lot less pain. So there's been some really good studies that have looked at this. This was a nice study that came out of Europe. So they looked at patients before and after bariatric surgery. So these patients lost on average of 85 pounds, so a rather extreme amount of weight loss. But what they found when they looked at joint biomarkers is there was a marked decrease, about 50% decrease in the actual biomarkers of cartilage turnover and cartilage breakdown. So your cartilage was actually getting healthier, or at least not degenerating as much after this surgery. So this is a really good reason to consider referring your patients with a BMI of over 40 or 45 with some arthritis to a bariatric surgeon, not to mention all the other potential benefits from that surgery. Well, what about mild weight loss? Especially in California, we don't experience large weight loss too much, but we do, or large patients too much, but we do have a lot of patients that are a little bit overweight. So there's a really nice style called the IDEA randomized clinical trial sponsored by the NIH. It was published about 4 years ago. And they broke people up into 3 groups. They put patients in a diet group, an exercise group, which was a control, and a diet and exercise group. On average, these patients only lost 12 to 15 pounds over the course of the study. And what they found was that everybody got better. Everybody dropped about 2 points in their WOMAC pain scale, which is a standardized outcome for knee pain. But the group that did both, they did diet and exercise, dropped about 50% in terms of their pain. They did a follow-up study that I didn't include that looked 2 years later. The patients in the diet and exercise group were doing significantly better and had an average pain score of 2.5. So the people that really bought in, did the diet and exercise, tended to do better for longer. So our recommendation for this is weight loss is a moderate way to improve pain. It's not going to help for patients with severe arthritis, but I think it's a really, really good thing to tell patients because it's something they can control, and patients feel great if they come back and say, hey, I lost 10 pounds. I feel a lot better. I may not need that joint replacement. Now, what about physical therapy? So physical therapy for knee pain due to arthritis is a little bit controversial because we don't change anything. And a lot of times what patients say is, well, why would I do physical therapy? Because it's not going to make the knee arthritis better. How does it put cartilage back in? And the reality is we don't know, but we do know that it works pretty well. So this was a systematic review in the Annals of Internal Medicine, and what they found that there was no single intervention with physical therapy. It wasn't exercise, it wasn't one particular modality that worked, but overall physical therapy consistently worked mildly to moderately well in all studies. What they did found is what I would call the gimmicky things. They didn't work too well. Orthotics, taping, ultrasound, things like that didn't seem to work quite as well, but when they were used in combination, they tended to be effective. And in this systematic review, if you just look at their box chart here, every single study favors exercise versus no exercise. It's not a huge benefit, but it's not no benefit. So I almost always recommend to patients, try physical therapy first. Moving down to middle finger, orthotics for osteoarthritis, knee sleeves, knee braces, in general, things that you can buy at Walgreens. If patients want to use it, absolutely, have them use it. May help with swelling, may help with air travel, but it's not going to change the biologic environment. When patients have isolated medial or lateral compartment disease, so this patient has worn out the inside of their knee, sometimes we'll prescribe an offloading brace, which if you look at the advertisement online, it looks phenomenal. It looks like one of those airline ads. You put this on, and all of a sudden the joint space is wide open. It doesn't really work like that. It's not that effective. This study that came out of one of the European studies in 2014 looked at outcomes when using an unloading brace. They found that overall patients felt better. So you put these unloading braces on to offload the compartment that's injured. Patients felt better, but the actual joint space widening was not any different. So you don't change anything that much, but just that little change, offloading a little bit, helps enough so patients feel better. For us, this really helps us pick who are going to be good candidates for an osteotomy or a realignment surgery. So what I usually do if people have really worn out the inside or outside of their knee, I will put them in one of these braces for about 3 to 4 months, see how they feel. A cohort of patients will say, that feels great, I hate the brace, please talk to me more about the osteotomy. I explain what an osteotomy is, and usually they run away for a few months. Patients that say they feel great, especially our older male patients that like wearing a brace, they just stay in it for years and years and years. They like the tan line that comes when they play tennis. So overall, our recommendations for bracing is that there's moderate evidence that these work fairly well. We have no support for using heel wedges or other orthotics, okay? So we don't recommend anymore using heel wedges, simple knee sleeves. If patients want to use it, great. There's no harm, but they're not necessarily going to show any benefit. So what about injections? So there's a variety of different injections. I use PRP because it gives me better self-image. Awesome. We can talk about steroid injections and Synvisc or other hyaluronic acid injections. I'm going to cover some of this now and some of this afternoon. And for a lot of this, you'll hear Dr. Lansdowne talk about PRP and stem cells. So corticosteroid injections are the most common injections that we use. We know that they can be somewhat risky, but what we don't typically tell patients is it's a combination of a numbing agent or a lidocaine or analog and a steroid. We know that it can transiently increase your blood sugar, especially if you're a more brittle diabetic. But what we don't typically tell patients is it's really the lidocaine that kills more of the cells than the steroid. So typically now we use a lot less lidocaine, or we try to use marcaine or ropivacaine because it's much less chondrotoxic. So this is a study we did a few years, like 6 years ago now. This is after just adding lidocaine. So green cells are healthy. After we add lidocaine, about 50% of the cells die in cell culture. So it's actually the lidocaine, not the steroid. And then the other thing patients want to know is, well, am I going to be awesome? This is a dated slide because now my med students don't know who Barry Bonds is, but this is a different class of steroid. So you don't get a big head or small other things when you take corticosteroids. So we know overall, no matter how you look at the data, that steroids have a mild positive benefit for short-term pain relief. So whether we look at pain scores, function scores, or overall function at 6 months where it tends to drop, we know that most studies will show that steroid is a limited benefit for a short period of time. So the way I use a steroid injection is if somebody has arthritis, they are going on a trip, or they have something they can't miss, I think it's a great temporizing solution. But I tell them we're not altering the biologic or biomechanical environment. So what about viscosupplementation? This is also my next career. I'm going as a clip art model as the happy arthritic patient when I turn 65. They all look so happy. It's awesome. So there's a variety of different agents. Even when studied as together or apart, there's no statistical difference in the outcomes from any of these agents. The main difference is in the amount of medication that you give versus the number of times you give it. So Synvisc, you give 3 times 1 week apart. Flex, I believe you give 4 times 1 week apart. In general, they all work about the same. They lubricate and cushion the joint, sort of. They're made from a natural substance similar to healthy joint fluid. It's basically a high molecular weight protein. It does improve viscosity, high molecular weight. We don't know how, but it does seem to decrease pain. It seems to decrease inflammatory mediators in the joint, but we don't actually understand the mechanism. Depending on who you ask, this is either a really effective treatment or a not very good treatment at all. So if you ask the American Academy of Orthopedic Surgeons, who they look a lot like me but older and balder, what they say is there is strong recommendation that we should not recommend this. And the reason is partially due to bias. If you ask an orthopedic surgeon, does it work? Well, it works, but it doesn't work nearly as well as a joint replacement. So compared to other tools that we have in our toolbox, viscosupplementation is expensive. We tend to use it a lot right before a knee replacement, and it doesn't seem to work that well in that cohort of patients. Conversely, if you ask the American College of Rheumatology, they say it's an effective treatment for moderate knee arthritis. But you think about what's in a rheumatologist's toolbox is very different from what's in our toolbox. So their bias is, this is the biggest gun we have right now. If we give you that, that's the best we can do. Our bias is we have a knee replacement. We can fix all your problems and give you a whole new set of problems that you don't have to worry about whether or not you need an injection. So the New England Journal did a really nice summary statement, and what they said was that current evidence would not advocate for the intra-articular use of hyaluronic acid for the management of knee arthritis. So that's the overall thing I tell patients is that realistically, I think it's worth a try. It may not be that much beneficial, but if it gives you relief, great. So I'm going to touch briefly on PRP. How many of you have had a patient ask about PRP and or stem cells? How many of you have done a PRP or stem cell injection? One guy, now you're awake. Awesome. Okay, good. So I've used it here. It's awesome. It's working. It doesn't work for my eyes, but I don't have dry eyes. It works for athletes. I realized when I was looking over my slides, this is a horrible collection of athletes right now. Tiger Woods, no. Kobe Bryant, no. So I got to get new athletes that have had PRP. And this stem cell guy looks super honest, so it's great. What's the evidence with PRP? So focusing, Dr. Lansdowne is going to talk about the evidence for PRP in other parts of the body. The evidence for PRP versus other injections is still rather limited in the literature. This was a nice study that came out last year from Rush University. They randomized patients to hyaluronic acid and PRP. What they found was overall there was no significant difference in most of the groups. The PRP group tended to do a little bit better at all time points. But what they found was when they really broke down the groups, the patients with a little bit lower BMI, less arthritis, tended to do a little bit better, and the PRP group had less inflammatory mediators. So they concluded that significant improvements were seen in patients in certain subgroups with PRP over hyaluronic acid. So I think this is a reasonable study to talk to with patients. And then there's a series of systematic reviews of the limited level 1 and 2 evidence. I think only in orthopedic surgery will you have 4 studies and 3 systematic reviews on those 4 studies. Awesome, good job. But all of them show moderate favoring of PRP over treatment groups. The interesting one, patient satisfaction, whether they're blinded or unblinded, all had a pretty strong benefit of PRP over the control groups. Overall, what I tell patients is that I think there's level 1 and level 2 evidence that there's mild benefit with PRP. There's not a lot, but there's mild benefits. There's very few side effects, and there's no long-term data on the natural history. We don't know if we're actually changing the biomechanical environment. So what about stem cells? So stem cells are a little bit more complicated, but they sound awesome. I think probably a third of for better or for worse, I have a muscle stem cell lab, so as soon as patients hear that, they want to know about stem cells. So I have a fair amount of my conversations are why I didn't use stem cells on my hair instead of PRP, but anyway. So what are stem cells? There's a different groups of stem cells. We focus mainly on adult stem cells. These can be mesenchymal, hematopoietic. We don't really talk about juvenile. And we don't really use pluripotent stem cells in orthopedics. Most of what we use are mesenchymal stem cells. What defines a stem cell is its ability to differentiate into multiple different phenotypes after some sort of differentiation agent. How do stem cells work? Stem cells do not have a conscience. It would be awesome if each stem cell had a brain. I injected stem cells into the knee. They looked around. They said, wow, there's not a lot of cartilage. I'm going to make cartilage today. That'd be awesome. They don't work like that, although that's really, I think, if you ask most orthopedic surgeons, that's kind of how we think about them. And it sounds like that's how they should work, but they really don't. And what we think more likely what happens is they see less cartilage cells. We inject stem cells into the knee. Stem cells are a lot like platelets. They have a tremendous abundance of growth factors and cytokines that tend to be biologically favorable. So they probably release these cytokines into the local environment. They don't really differentiate. If you look at either animal or human studies, we don't see a change in cellular morphology. We don't see more cells after any treatment. So it's probably dependent on stimulating the local cells within the environment. There's very little evidence on whether or not this works. In fact, there's so little evidence that the consensus statement by the British Journal of Sports Medicine this year was, the studies are so bad, we can't recommend that you actually even look at the studies, which is a pretty glaring comment on orthopedic literature. I wanted to point out, I don't know if this is in the syllabus, this was in the American College of Rheumatology meeting last month. So this is a new drug called Ibuprofen or something. They really try to name that orthopedic surgeons wouldn't be able to use. And what they looked at was over a course of 2 years, they gave this drug, and they looked at cartilage, the amount of cartilage within the knee with a sequential MRI. And for the first time, what they show is that giving 100 micrograms of this drug over repeated doses actually allows a little bit of cartilage to regrow. And you think about that, that's really exciting overall. This is the first time I've ever seen any drug not be on this side of the curve. Now, the caveat is if you look at where we are in the curve, it's grown 0.03 millimeters. That's not a lot, but it's really exciting that if you could slow the progression or even improve cartilage a little bit, that's really exciting. So they're in phase 2 trials now. They will be going to phase 3 in commercialization very soon. So the last thing I'm going to talk about is knee replacement. This is the final common pathway for all patients with severe knee arthritis. The way I tell patients, it's like having a tire. Your tire is not only worn out, you lost the tire, you're kind of running just on the rims. Knee replacement is a bad word for for what we do. Knee replacement should be called a knee resurfacing. We tend to do design cuts to shave off a little bit of the bone and cap it with metal and plastic. It is a really good procedure for low to moderate demand patients. It gives immediate pain relief, good range of motion, and really good results at 10 to 15 years. And you can go back to doing some, but not all the activities that you want to do. I'm just going to conclude with these 2 slides. The 2 questions we get most often are, how long does a knee replacement last? And does a computer or laser do a better job than a surgeon? It sounds awesome to use a laser, but it does. It actually works pretty well. So this was a really good study that answered both. This was a study out of Korea. So what they did was they took bilateral total knee patients, and one side the surgeon did, the other side it was done with computer navigation. At 12 years, everybody had both knees still in them, and there was no difference in function. So you can say at 12 years, there's a really good chance you're functioning well. You don't need the computer navigation, but if you want it, great, you'll be doing really well. So just to conclude, my algorithm, when I see patients with knee arthritis, I divide the patients into what I think their risk factors are. So if they're modifiable with weight or activity, I'll intervene with physical therapy, diet. There's really good level 2 evidence that says it works. If it's non-modifiable, I kind of talk to them about that and say, we can't fix everything. We don't have time machines, and then start working on the possible modifiable things. For possibly modifiable, I do look at their alignment and consider bracing and an osteotomy. If they're really larger, I will talk to them about maybe talking to a general surgeon. It may help them both with that and all other parts of their life. And biologic treatments, I think decreasing inflammation, whether with oral medication or steroids, is beneficial. And the final common pathway, I say if worse comes to worse, we can do a surgery where 90% of you are happier and back to doing the way you want to do things. I think that's great. So thank you.